with genetic factors like Down syndrome, certain genetic syndromes predisposed to congenital disease, environmental factors that the mother may be exposed to during pregnancy, like infection like rubella, alcohol, drugs, alcohol, phenytoin, lithium, thalidomide, smoking, maternal illness, diabetes, PKU, systemic lupus, obesity. All these factors can contribute to congenital disease. And to get a good understanding of congenital disease, you have to go back to embryology. And this at 18 weeks of gestation. You have the primitive blood vessels forming around here. Then 2 days later, you have what we call endocardial tubes. And then 21 days, they will fuse. And this 22 days. Now, this top part is a truncus arteriosus, who is going to give rise to the aorta and pulmonary artery. Then there's a primitive ventricle, and the atria will come from here. So it's going to loop day 23, going to loop this way, this direction, counterclockwise. It loops counterclockwise, so the blue will come up, and then this will be down. This day 24, day 35. So this is what going to form the ventricles. This is the truncus arteriosus, which will form the great vessels. And these are the atria. Over here, the same thing. This is the process of partitioning. The endocardial cushion, these are 4 regions of tissue that are here. They give rise to the AV valves, tricuspid and mitral valve, the primary part of the atrial septum, membranous part of the ventricular septum, and then the AV node will all come from here, this section. So back to embryology. During septation, there's a membrane that grows from top called septum primum. It grows from top down. Then another one will grow, a secundum septum will grow next to it and come down. They don't fuse, they sort of overlap each other and leave a hole between them called a fossa ovalis or foramen ovale, which is to allow blood to be shunted from the right side, the bottom part of the body, across the fossa ovalis to the left side, because blood on the right side, which normally should go to the lungs are a dead space inside the womb. There's no reason for blood to go there. So from the vena cava, the inferior vena cava, the blood is shunted across the fossa ovalis to the left atrium. And this is the primum septal membrane, and this is the secundum, and they overlap each other. And in a primum defect, this part doesn't form, and then the secundum defect, the middle part doesn't form. And then you can get a defect up here called a sinus venosus defect. The same thing is at 30 weeks. The endocardial cushions are here forming, the ventricles are forming, the atria are forming. So other glitters is not gold. Somebody can look normal like all of us here in the room on the outside, but internally things may go wrong. As these tissues form, and especially with the looping, sometimes it's incomplete or it goes in the wrong direction. So one chamber can end up in a different position, or the great vessel can end up in a different position. So other glitters is not gold. Now, what happens when there's abnormality during this process? And what can happen? There can be hypoplasia where structures are not formed well, or aplasia where they don't develop at all. There can be obstructive lesions, can have septal defects, cyanotic defect, can have problems with the valves, and then great vessels. We can have a combination of these. back again to embryology. During the fetal life, the fetal gets its oxygen supply from the mother. It comes through the ductus venosus, which is coming this way. It goes through the liver and then join the IVC, and it directed across the fossa ovalis. And this is the umbilical arteries going to the umbilicus connected to the mother. And then there's an umbilical vein which turns into the ductus venosus in the liver, and then to join the IVC to go into the right atrium. So at birth, a couple of changes take place. Now, the fossa ovalis is supposed to close. About 15 to 20% of people, it doesn't close, stays open. The ductus arteriosus is here. It's a connection between the aorta and the main pulmonary artery. Now, the blood from the inferior part of the body coming through the IVC goes over through the fossa ovalis to the left atrium. Blood from the top part the venous blood, the SVC, and then goes into the right ventricle. And when it gets to the pulmonary artery, because the lungs dead space, is shunted across the ductus arteriosus into the descending aorta. So that's also supposed to close a few days after birth, and then the ductus venosus is also supposed to close. But sometimes these structures stay open. So back to the fetal circulation. So in the postnatal life, venous blood from the body comes to the right atrium, right ventricle, the lungs, then left atrium, left ventricle, back to the body. In the fetal life, from the body, it comes to the right atrium, then through the fossa ovalis, the IVC blood is shunted to the left atrium. Then from the top part of the body, it comes to the right ventricle. The reason why the blood has to go through the right ventricle is if blood doesn't get to the right ventricle will not develop. So the blood has to go to the right ventricle. Then from there, when it is going to the lungs, it's shunted through the ductus arteriosus to join the aorta going to the body. And then after delivery, this is supposed to close, this is supposed to close. Now, when we have congenital disease, you can have a lot of problems, arrhythmia, endocarditis, stroke, heart failure, pulmonary hypertension, heart valve problems. Now, there are many diseases classified as congenital disease. We classify them as simple defects. These are atrial septal defect, the secundum type, ventricular septal defect, that is isolated VSD, aortic stenosis, interrupted aortic arch, pulmonic stenosis, a small ductus arteriosus, or mitral valve disorder like parachute mitral valve. Then those with moderate complexity are primary ASD, Sinus Venosus ASD, a light PDA, Epstein's anomaly, aorta, left ventricle fistula, AV septal defects, pulmonary valve stenosis, sinus of valsalva aneurysm, subvalvular and supravalvular aortic stenosis. Then we have the complex type. These are the cyanotic defects. These kids are born and they are blue. That is hypoplastic ventricle, pulmonary stenosis with atresia, tetralogy of Fallot, D transposition, L transposition, truncus arteriosus, tricuspid atresia, double outlet ventricle, mitral atresia, and anomalous pulmonary venous return. Yeah, and we went through this earlier on. This is the development of the septum. This is the primum septum forming, and then the primum septal membrane coming down, and this is the secundum septal membrane also coming down. They overlap. The same thing here. Now, we're going to start with atrial septal defects, and there are 4 types. There's a primum type, the secundum type, the sinus venosus type, and the coronary sinus type. The secundum is the most common type, about 60 to 75% of patients who have this. And that is, there's a deficiency in the septum, the central part. And because left atrial pressure exceeds the right atrial pressure, blood will shunt from left to right. And therefore, it leads to right atria and right ventricle volume overload. And then the pulmonary artery has to carry all this excess blood going into the lungs. The pulmonary artery is very, very sensitive to volume. And that oftentimes, if you allow too much blood to go across the pulmonary artery, they can develop pulmonary vascular disease, especially with large VSDs. So what the pediatric cardiologists will do is they call PA banding, where they'll put a band around the pulmonary artery and tighten it to create artificial pulmonary stenosis. When you do that, you increase the pressure in the RV, so you decrease the pressure between the left and the right ventricles, and thereby you minimize the shunt across the PA to prevent the case from developing pulmonary hypertension, pulmonary vascular disease. And at a later stage, when they go to repair, then they remove the band. So this is a secondary defect, blood coming from the left atrium to the right atrium. It leads to right cardiac chamber enlargement, secondary defect. And it is seen here on 2D echo, the right atrium, left atrium. So let me see. So this is a secondary defect, the shunt across. This is a T secondary defect, a shunt, left to right shunt. Okay, this is a secondary defect by some fenestration here. We can see flow going across it. The fenestrated ASD. This is a secondary defect, the subcostal view going from left to right. Okay. Now with the sinus venosus defect, what happens is the defect in the top part of the atrial septum, and it's associated with anomalous connection of the pulmonary vein. So there are 2 types. There's a superior vena cava type and inferior vena cava type. The superior vena cava type, the right upper pulmonary vein enters the right atrium next to the SVC. So it leads to volume overload on this side. And sometimes you can miss it on a transthoracic echocardiogram. The inferior type, the vein enters close to the IVC. Okay, so this is a T, this is a bicaval view. The SVC is here, that's the SVC coming in. This is the atrial septum, and that is the right upper pulmonary vein coming in here. Normally, there should be no defect between here and here. The right upper pulmonary vein should enter in here, but you see there's a defect here. That's a classic way to demonstrate a sinus venosus ASD. That's the T about 120 degrees by bicaval view. You see the defect in the membrane. And this is a sinus, the other type, the sinus venosus defect. Okay. And what happens is that sorry. I mean, coronary sinus defect, that's the fourth type. But the coronary sinus defect, the coronary sinus runs behind the left atrium. And oftentimes, there's a defect in the superior part of the coronary sinus, which creates a shunt between the coronary sinus and the left atrium. And most of the time, these patients also have persistent left SVC. When the left SVC, the SVC in the fetal life, there are two SVC, right and left. And the left is involuted during development. But in the setting of coronary sinus defect, the left SVC is patent. So it drains blood into the coronary sinus. And if this is also called unroofing of the coronary sinus, the blood will dump into the left atrium. This is one defect that can easily be missed when you do a bubble study from the right eye. The best way to demonstrate is to do a bubble study from the left eye, and then it will dump into the coronary sinus. So you see the bubbles enter the left atrium even before it comes to the right atrium. So this is a coronary sinus ASD. Now, the primum ASD is part of what we call AV canal defect. These defects, they go by various names, and they come from the endocardial cushions. Endocardial cushion are 4 ridges of tissue. There's one here, one here, one here, and one here. It forms the central part of the heart. Now, this is also called AV septal defect, AV canal defect, endocardial cushion defect. It all refers to the same thing. So you have a deficiency in the atrial septum at the lower end. That's a primum defect. You have a defect in the membranous part of the ventricular septum. That's a membranous VSD. And then they also tend to have problems with the tricuspid valve and the mitral valve. And one way to tell, especially if you're imaging a patient and you don't have an op report, sometimes these patients have no idea what has been done to them as kids. All that they will tell is, oh, I was born with a heart defect and I was fixed. I don't know what's wrong with me. They don't come with their parents, so you have no idea what you're dealing with. And the AV valves, when the heart is well formed, normally the tricuspid valve is apically displaced it's towards the apex than the mitral valve. When you see the two valves coming at the same plane, you always suspect AV canal defect. The valve take off at the same plane. The tricuspid valve is here, the mitral valve. Normally, the tricuspid valve should be a bit towards the apex than the mitral valve. And this patient can also get deformities of the mitral and the tricuspid valve. You should always watch for that. So in addition to having a defect in the membrane, I mean, the septal membrane, also look for a problem with the AV valves. They get what we call a cleft of the AV valve. You can get a cleft mitral valve and a cleft tricuspid valve. The AV node also is here, is part. So these patients are later on in life, they are prone to AV block because of this defect. So this is a cleft mitral valve. We look at the mitral valve here. This is a posterior leaflet. This is anterior leaflet. You look here, there's a deficiency here. Yeah, that's a cleft. The surgeon tried to repair it, but it can get worse. And most of the time, this patient will need mitral valve intervention in adult life, most likely mitral valve replacement. There's a cleft here. I see the anterior leaflet has 3 pieces. There's one here, and then the posterior leaflet. That's a cleft mitral valve. Okay. Now, the ventricular septum. The classification, there are many names out in the literature but the simple way to look at it is between the mitral and then if the defect is between the AV valves, it's an AV canal defect. Okay, so membranous defect. Then we can have a defect between the tricuspid valve and the aorta, which is membranous or perimembranous defect. And we can have a defect here and a defect here. We call this supracrystal, or this corner defect, or this called malalignment defect. Then you can also have a defect in the muscle layer or the septum. These are the muscular VSDs, which is over here. This part is called, this is another classification, this is called the inlet VSD. So this is an inlet VSD. This is a muscular VSD. If you angle the probe so you see the aorta in view, then this becomes the membranous. And then in this view, this is a subarterial, because the pulmonary artery is here, and there's a LV outflow tract. These ones tend to affect the aortic valve, so oftentimes it's associated with aortic regurgitation. So they have to be repaired. If it's a small muscular defect, then oftentimes we can watch, even if it's membranous, it depends on how much shunt is going across. If it's restrictive defect means there's a small degree of shunt. There's still a large pressure difference between the left ventricle and the right ventricle. Oftentimes, it will not lead to pulmonary hypertension. So we tend to watch this and not close it. But if it's a large defect, which can lead to pulmonary hypertension and Eisenmenger, then you have to close it. But before you close it, then you do the PA banding before you close it. So this is a VSD. This is a parasternal long, left ventricle, left atrium, aorta. This is a VSD into the right ventricle is a shunt. And when you are doing your studies, just put your probe along here, your signal, to see if you see any shunt. Then Doppler it to see the gradient across the defect. So this is an AV canal defect because there's a deficiency in the membranous part here and also here. Okay, now you can see a flow here, and there's also a flow here. Okay, so this is another VSD. The defect is here, and that is the flow. This is also a VSD, the flow going across left to right. But if they have, unfortunately, they come to you late and they have Eisenmenger, then you may not get any flow at all, because when they get Eisenmenger, the pressures are equalized. There's no pressure gradient between the ventricles. They are the same, so there's no flow. So this patient, you listen to the heart, you may not even hear a murmur. Okay. So that's a VSD going across.
After focusing like with the VSDs, it's pretty late when you see the RV dilate. Usually,
Yeah,
it just
that RV
dilated. Goes to the PA initially, right? So eventually start. It's a high volume of flow over time. So the RV side is not a clue. You're thinking VSD.
No,
it's really late stage, correct?
Yes. Yeah. So this is muscular VSD right over here. Okay.
Can I ask one more question? It's annoying, I know. And on the short axis view, that gives you clues, right? It's membranous, or depending on looking at
we use the clock. Okay, and if it's between after 9 o'clock going, and that is the supracrystal subarterial type. And if it's between 8 and 9 o'clock, that's the membranous type. After 9 o'clock, that tends to be the ones associated with aortic regurgitation that you have to fix. If it's membranous and there's not much volume across the defect to the right side, we can watch them. Yeah, because as long as the shunt fraction is below 1.5, they don't develop pulmonary hypertension unless something else comes in later. But If it's above 1.5, then the risk of developing secondary pulmonary hypertension, therefore leading to Alzheimer's, is high. So you have to close.
Thank you.
Okay, so coarctation. So the aorta, when it's developing, it's like a tube and it gets canalized. In coarctation, what happens is a part of the aorta doesn't develop, so it's like a narrowing, a constriction. And this is the common site of the coarctation. It's classified as ABC. The most common type is at the time where the ductus is coming in. And then we have here another classification, pre-ductal. That is if the coarctation before the ductus. Post-ductal is after the ductus arteriosus. So coarctation is here. So this is the ABC. The B is a pre-ductal coarctation. So it's here. And then this is the most common type. And then this is a post-ductal. The reason why we have to fix it is if you don't, it can lead to many problems. So this is MRI, that's the aorta coming. You see it's narrowed here. This is the coarctation that has been stented. This is the coarctation here. And it's not common. It is common for this patient to get aneurysmal disease. This is the aorta, this is aneurysm at the point of the coarctation. And coarctation, about 50 to 70% of patients with coarctation will also have bicuspid aortic valve. The two go together. 50 to 70% of bicuspid valve will have coarctation. 50 to 70% of coarctation will have bicuspid valve. They go together. So anytime you see coarctation or bicuspid valve, look for the other. They go together. And morphologically, the aorta in these patients, even isolated bicuspid valve or isolated coarctation, the aorta is abnormal. It's not a healthy aorta. If you look, for years, we thought that patients with aortic valve got aneurysmal disease, and we thought it was a pressure effect. But no, it's not. It's a morphological abnormality, because even when they are born and you take at autopsy, you look at the aorta under the microscope, they have cystic medial necrosis, just like somebody who has malfunction. So the aorta is abnormal from day one. So they get aneurysmal disease. So they are also prone to dissection. Yeah. And so aortic valve, bicuspid aortic valve coarctation, they are prone to dissection. Even when the aorta is not aneurysmal, it can still dissect because it's morphologically not normal. Coarctation is more common in males. Is more the most common types at the point of the ductus arteriosus. It is a one study say 85% of children coarctation have bicuspid valve. And when you're doing a study on patient coarctation, the arch view, the suprasternal view is very, very important. And then you Doppler that area and you see the pressure gradient. Yeah, this is about 4, which is significant. And then you also have to Doppler the aorta. And the normal abdominal Doppler pulse wave, it has a systolic flow, and then there should be no flow in diastole. But in coarctation, there's a still continuous flow down the aorta in diastole. And then the peak, it decreased, and then it continues during diastole. This is abnormal. That's indicative of coarctation of the aorta. Now, in coarctation, because depending on the severity, sometimes the body tries to compensate by developing these collaterals. This is from the subclavian and then the intercostal arteries around the point of the coarctation to feed the lower part of the body. So when that happens, oftentimes you will not see a pressure gradient between, say, the right arm and the legs. But especially if they have adequate collaterals coming this way to feed the right I mean, the lower half of the body. And that can fool you. That you check pressure in the right arm, you check it in the right leg, there's no pressure difference. You may say that, oh, the patient does not have significant coarctation, maybe because we have all these collaterals forming around the coarctation to feed the lower half of the body. And one of the best way to pick this up is an MRI or a CT scan.
I have a question.
Uh-huh.
So patients who come in with bicuspid aortic valve first diagnosis, we should be doing a CT chest
For aneurysmal disease, yes.
So anyone who has new diagnosis of bicuspid aortic valve. So do you do just a non-contrast, or do you do a CT angiogram?
A CT angiogram will be fine. Just to look at the aorta, at least you want to get a baseline size of the aorta, and then follow it with time, because they are prone to dissection, and the aorta will grow because morphologically it's abnormal. They have cystic medial necrosis, so over time, especially they have uncontrolled hypertension, it's going to grow very fast.
Because I can sometimes start just with a non-contrast CT to see if everything is okay, and if they have some abnormality, then go ahead and do a CT. I don't know what standard of practice.
Yeah.
Well, do you just do a CT angiogram?
Oftentimes the ones I've seen have been already imaged up.
Really? I have some.
We're on the rail you. Just look at it like, so just like surveillance, like once every 3 years, every 5 years.
Yeah, I mean, if it maybe once every 5 years, if it's not growing.
And you would recommend a CT angiogram?
Yeah. Now, maybe if you're seeing the patient for the first time, then it's best to maybe repeat in a year. If it's in a year, it has grown by more than 0.5 centimeters in a year. That means there's an aorta that's growing very fast. So then you have to fix it. But if you say you've done it a year and then the next year still the same, that means slow growing. You can wait for maybe about 5 years and repeat it.
Thank you.
And this is ductus arteriosus between the aorta and then the PA. And most of the time it will close, but sometimes patient will come to the lab that this has not been diagnosed, and the PDA is patent and through adult life. And then it leads to secondary pulmonary hypertension because you are shunting blood. Since the pressure, there's pressure difference between the aorta and the pulmonary, both in systole and diastole. You have blood coming this way continuously. That's why it produces a continuous murmur. It leads to a secondary pulmonary hypertension, and then Eisenmenger syndrome. So this is one of the best views to pick this up is a suprasternal arch. The suprasternal view. This is the aorta, and that's the pulmonary valve is here, and that is a continuous flow from the PDA going back, during systole and diastole. Now, aortic stenosis. It can be at 3 levels. It can be either at the level of the valve, or we can also get what we call subvalvular aortic stenosis, and it can be supravalvular aortic stenosis. Supravalvular aortic stenosis is common in a condition we call it Williams syndrome. It's a chromosome 18 abnormality. They can have other problems like hypercalcemia. You have a gregarious affect. And so when you look at the airflow tract, always pay attention below the valve, at the level of the valve, or above the valve. Now, so it can be below the valve, at the valve, or above the valve. The most common valve abnormality is bicuspid valve, where you have 2 leaflets instead of 3. It can also be quadricuspid. I've seen about 5 or 4 cases of quadricuspid aortic valve, and it also can be unicuspid, just a single leaflet. I mean, they are all abnormal. It has a normal valve has with tri-leaflet. So that is a bicuspid valve. It has fusion. This is a tri-leaflet valve open, and there's a bicuspid valve, like a fish hook mouth. And then it's associated with aneurysmal disease. And then the aneurysm can be in these types. There's a normal aorta. It could be either supra-coronary type. That's the most common type. In this study, about 64% of patients. It will be above the coronary takeoffs, okay, here, or it could be the Marfanoid type. This is a type of aortic dilatation we see in Marfans. It starts right at the root all the way. Or it can be the tubular type. It starts from here all the way. 1, 2, 3, either one can go over by bicuspid valve. This is a subaortic membrane. This is a valve here, and you see this ridge here. And what it does, it creates a pressure between this and the valve. So if you're at the outflow tract and you see, anytime you see a turbulence here, put your cursor here and track it down. If they have a subaortic membrane, as you come this way to here, you see a pressure step up. You come here and the pressure will drop before you come to the valve. The aortic membrane, subaortic membrane is right over here below the valve. And it leads to this a turbulent flow at the point of the aortic membrane, subaortic membrane. And it leads to aortic regurgitation. So in some centers, when they pick this up in the children and they have aortic regurgitation, they will replace the aortic valve and resect the membrane at the same time. The problem with subaortic membrane is it can grow back. Even after a successful resection, it can grow back. It's always, when the patient comes to the lab, they tell you, oh, I've had subaortic membrane resetted. So pay attention to the LVR flow tract because it can grow back. The same with coarctation of the aorta. It can also grow back, even when you've resected it. And what the surgeons can do is sometimes they can reset it and do end-to-end anastomosis. Sometimes if the gap between the aorta is big, then they can put a dacron graft between them. Sometimes they use a subclavian and open it and use it to repair. We call it patch repair. And even if it doesn't grow back, they can also develop aneurysmal disease at the point where the coarctation was. So coarctation can recur. Subaortic membrane can also recur. It can grow back. This is the subaortic membrane and your CW profile. If it's an aortic valve, you have a denser portion here, and this is dense across the whole Doppler profile. This is hypertrophic cardiomyopathy with a dagger shape that you see. Okay. Now, Epstein's anomaly. In Epstein's anomaly, what happens is there's failure of delamination of the tricuspid valve as it develops. So the tricuspid valve leaflets are adherent to the myocardium, so they are displaced apically. So this is one leaflet here, the septal leaflet is here. So there's mild coarctation, and part of the right ventricle is incorporated into the right atrium. We call it atrialized right ventricle. So this is all considered the right atrium, and this is what is considered the right ventricle. So there's no these two leaflets cannot come together, so it leads to severe TR. And about 50 to 7% of these patients can also have secundum atrial septal defect. And they are also high incidence of accessory pathways. So they get WPW. They get both manifest accessory pathway or concealed accessory pathways. So that's the Epstein's anomaly. And it can lead to heart failure, failure to thrive. And when this is detected, what the surgeons will try to do in the hands of a good surgeon, they will try to resect the valve and bring it here and try to repair the valve. If they try and they cannot get a good repair, then they remove the valve and then put in a tissue valve, either porcine or cow valve. And these valves you have to follow them over time because they get scarring and you become fibrotic, and the valve will have to be replaced from time to time. But this is Epstein's anomaly. It's often associated with secundum atrial septal defect. So this Epstein's, the tricuspid leaflets are here. This is all part of the right ventricle, called atrialized right ventricle. This is an autopsy specimen. This is a right atrium. This is the atrialized portion of the right ventricle, and this is the free wall. So this is what is the functional right ventricle that we have here. And then we have interrupted aortic arch. So you can get interruption of the arch at a couple of places. It can be here between the subclavian and then the right common carotid, or between the right common carotid and the left common carotid, or it can also be here. Then in this patient, the ductus has to stay open because that's the only way for them to get blood to the lower half of the body. So when the kids are born and the surgeon cannot operate on them right away, we give them prostaglandins to keep the ductus open until we can go in and fix this. And you can either put a Dacron graft between the two to bridge it here, or sometimes they can do a bypass before you reset the ductus. It's very rare, but you can see them. And the PDA is the only means where we can get blood to the lower half of the body. This is another congenital defect one can be born with called triatriatum. And that's a membrane dividing the left atrium into two chambers. There's an upper part or superior part and an inferior part. And there's a fenestration through that membrane. And therefore it creates a functional mitral stenosis where there's pressure buildup behind this, and that can lead to something equivalent to mitral stenosis, congestive heart failure. That is called triatriatum, and that can be resected. And then once again, it can regrow. So we have to pay attention to this in the adult life. So this is called triatriatum. This is the membrane dividing the atrium into two halves. This is here, this is the membrane. This is a proximal part, this is a distal part. And there will be a fenestration between them so that the blood goes through that to enter the left ventricle. Now, we go to the blue syndrome babies. These are tetralogy of Fallot, double outlet ventricle, truncus arteriosus, hypoplastic left heart syndrome, AV canal defect, tricuspid atresia, and then Eisenmenger. In tetralogy of Fallot, Antoine Fallot described it. It was a French pathologist who described it years ago. There are basically four abnormalities. There's abnormality at the right ventricular flow tract. Either the pulmonary valve does not develop, or it developed by very small artery, or sometimes they have a fibrous tissue below the valve, so it obstructs flow at the pulmonary outflow tract. For that reason, the way the body gets around is as a compensatory effect to not to allow the membranous part of the ventricular septum to form. So the blood will be shunted across that septum into the left ventricle. Then there's right ventricular hypertrophy and overriding of the aorta. So the aorta sits on top of both ventricles. receiving blood going to the body. So these kids are born blue, and one of the initial intervention the pediatric surgeons will do, because of the outflow tract obstruction, they are not getting enough blood to the lungs. So we keep the ductus open, the PDA open, and then they do a couple of shunting procedures. And then recently, a patient came to the lab who had a water sink shunt. The water sink shunt is a shunt between the ascending aorta and the right pulmonary artery. It's a water sink shunt. Or they can do a left pulmonary artery, a descending aorta shunt. It's called port shunt. And they also can do a central shunt where they can create a connection between the PA and the aorta going. The problem with these three shunts is if the surgeon is not careful and they make the shunt too generous, you can get more blood going to the lungs. You can trigger secondary pulmonary hypertension. So it has to be of the right size, so you're not getting more blood than you need to the lungs. But the best shunt that has sort of withstood the test of time is called BT shunt. And that is a connection between the subclavian and the pulmonary artery. We can do both one side or both sides. It could be a left or right BT shunt. Initially, when Alfred Braylock and Helen Tarsik published their paper, what they did was to cut the pulmonary artery and the subclavian artery and tie to the pulmonary artery. But these days, they use what we call a modified shunt, where you use a Gore-Tex material and connect the subclavian to the pulmonary artery and get blood to the lungs and let the kids grow. And then when they go in to repair the tetralogy, then they will remove the shunt and then reconstruct the right ventricular outflow tract and then patch the VSD. Initially, when the surgeons were doing the repair, what they did was we call transannular repair, where they'll reset a lot of the right ventricular outflow tract and then leave this patient with severe pulmonary regurgitation. Then later on in life, they will need pulmonary valve replacement. Now, if the pulmonary, sometimes what the patient, in addition to the outflow tract obstruction, they can get stenosis of the pulmonary artery, both the main and the branch PAs. Or sometimes the outflow tract may be small, that is not difficult to do a good reconstruction. Then they can put what we call Rastelli conduit. And that's a Dacron graft. And that's it put between the right ventricular outflow tract to the pulmonary artery for blood to go through. The Rastelli conduit gets canalized and gets fibrotic over time. So that has to be replaced from time to time. So these patients, when they come to the adult lab, one of the areas of attention when you are imaging them is the right ventricular flow tract. Look at the pulmonary valve and see either they have pulmonic stenosis or pulmonary regurgitation, or if they have a Rastelli conduit, they have obstruction at the outflow tract. And then you pay attention to the size of the right ventricle and the function of the right ventricle. These patients are never cured. You fix them and they come for surgery one after the other to get blood to the lungs. And depending on the severity of the lesion of the right ventricular outflow tract, that will determine how often they need intervention. I've had a 35-year-old patient who by the age of 35 had 8 cardiac surgeries. And I've had 42-year-old patient who has had only 2 cardiac surgeries. It all depends on how severe the lesion at the right ventricular outflow tract is. Then the double outlet right ventricle, what happens in these patients is both The great arteries, the aorta and the pulmonary artery are sitting on top of the right ventricle. And this patient also has a VSD. So the surgeons will put in a Rastelli conduit and direct blood from the right ventricular flow to the pulmonary artery, and then close the VSD, and then direct the aorta towards the left ventricle. And the VSD, they can have erosion of the patch. They can have fibrosis of the Rastelli conduit, and that also have to be replaced from time to time. Then in truncus arteriosus, if you remember what I showed you earlier, that the truncus arteriosus gives rise to the great vessels. And there are 4 types. In type 1, you have the common trunk come up, then it will split into 2. That is the type that can be repaired. And the surgeons can separate them and put a conduit, the Rastelli conduit from the RVOT to the pulmonary artery, and then direct the aorta to the left ventricle. In type 2, the common trunk comes up, and then you have branch arteries coming off the side going to the lungs. Type 3, the branch arteries come up from the superior part. In type 4, all that you have is collaterals going from the aorta to the lungs. So type 2, 3, and 4 are not repairable. These patients are left cyanotic. So they have cyanotic heart disease for the rest of their life, and the only way is to do heart and lung transplant. A hypoplastic left heart syndrome. This comprises several types of lesions. What you have is you have either mitral stenosis or mitral atresia plus aortic stenosis or aortic atresia. That is, both left-sided valves are abnormal. They don't form well. And because the mitral valve doesn't form well, the left ventricle doesn't grow. So they end up with, basically, the left ventricle is very, very small. They have 3 chambers, and you have to do multiple surgeries. The same way these patients get shunt early in life to get blood to the lungs. Then the right ventricle, which is developed, you use the right ventricle to serve the systemic circulation. Then then later on, you can do what we call Fontan palliation to get blood to the right side, from the right side to the lungs. AV canal defects is what we talk about, or the AV septal defect or the cardiac cushion defect. That is primum and secundum septal defects, and then the cleft mitral and tricuspid valve. In tricuspid atresia, the tricuspid valve doesn't develop, so you don't get enough blood going to the right ventricle, so the right ventricle doesn't develop. These patients also have a 3-chamber heart that they will need multiple interventions. Then ultimately we need a heart transplant. So they will need heart transplant. Hypoplastic left heart syndrome will need heart transplant at some point. Trunk type 2, 3, 4 truncus will need heart transplant at some point. And then an unrepaired primum ASD, VSD, PD of Eisenmenger, these are all have secondary pulmonary hypertension, so they have Eisenmenger syndrome. They cannot be fixed except for heart and lung transplant. So this is type 1 truncus. Okay, this is a truncus arteriosus, and the great vessels split over here. So what the surgeons can do is they can patch this to here and close the VSD, and then cut the aorta here and put what we call a Rastelli conduit from here to here to get blood to the from the right ventricle to the pulmonary artery. In type 2, the pulmonary artery don't develop. You have a small artery coming from here and here going to the lungs. Type 3, They come from here, Type 4, the pulmonary doesn't develop. All that you have is the collaterals coming from the aorta and feeding the lungs. So this is a hypoplastic left heart syndrome. This is a mitral valve doesn't develop. This is all that there's left of the aorta, left ventricle. And the aorta doesn't develop. And aortic valve doesn't develop. Because of that, the aorta is very, very small. So the intervention procedures that can be done right at birth is the surgeons can do what we call a Glenn shunt. The Glenn shunt, what we do is that SVC is coming this way, you resect it and tie it to the pulmonary, so that blood from the upper part of the body comes and then goes into the pulmonary. It doesn't come to the heart at all. And you can do what we call bi-directional Glenn. You tie it here so it goes to both lungs. The other is stage 1. Then the stage 2 procedure, what they will do is, because this pulmonary is well formed, they will cut the pulmonary trunk here and then move it to reconstruct the aorta. Which is small. And then they can put a shunt from the right ventricle to the PA to feed the lungs. Then let the kids grow. So when they reconstruct the aorta with a pulmonary artery, then the blood coming here will feed the body. Then later on, the third stage, they will do a fontan where they'll place a conduit from the IVC to the pulmonary artery. So this is used to serve the systemic circulation, and the blood is rerouted to the lungs through this connection, the Glenn shunt and then fontan. But this case will grow and they will need a transplant. Years ago, all these children died. But with the advances in technology, they are now surviving into adulthood, that very soon you will see these patients coming to the adult lab who have had these complex surgical procedures. And unfortunately, the human anatomy is so unique and so complex that when you take the pulmonary artery or part of the aorta and use it to construct the other great vessel, that's not the end of the story. The point of insertion, they tend to develop problems. They can develop aneurysm at the point of insertion. So they need to be followed up for the rest of their life until they can get heart transplant. So this is hypoplastic left heart syndrome. This is the aortic, mitral valve. This is all that's left of the left ventricle. This is the aortic valve. So the right side is well developed. This doesn't. So you're going to use this to pump blood to the aorta. And you're going to use this part of the pulmonary to reconstruct. Take the pulmonary, then you reconstruct the aorta.
And on this one, you just have a 2-chamber heart, really, right?
Yeah, basically have a 2-chamber heart. Yeah.
Because you're putting the other one straight to the lungs.
Yeah.
So you don't have to have the right.
Yeah, exactly.
The right into the left.
Exactly. You sacrifice the right to serve the left, and then you direct the blood from the right side to the lungs artificially through the Glenn shunt and then the fontan. Okay. Yeah. And for that reason, when we do the fontan, that's not the end of the story, because there's no pump behind this pushing blood to the lungs. Basically, it's passive flow. The blood just flows and goes to the lungs. They develop venous hypertension here, and that goes down and affects the liver. So they get a lot of complications. They get hepatic congestion that leads to cirrhosis, eventually to liver cancer. These patients will need heart transplant. Even these days, we are doing, by the time they go to transplant, we do heart and lung transplant. The one patient I sent for a heart transplant, this was 2000. She was 32. I sent her for transplant for fontan. She got the heart. 48 hours, the heart died. Wow. It was useless. We put her on an artificial heart machine. We were so devastated, but we were lucky. In 48 hours later, we got another heart for her. So we transplanted her. She got 2 hearts in a period of 4 days. Now she's now 50-something years old. She's still alive, but now she had developed liver cancer because of all the passive flow from the fontan that affected the liver. Yeah, so these days, most places I say Mayo Clinic, even if they don't have signs of liver cancer, they'll still do liver transplant because they will get it, just a matter of time. So they'll do heart and liver transplant. So this is the AV canal defect. So this is a primum defect here and the membranous defect. And this case, so severe, the AV valve even did not develop. This one is inoperable. We can't do anything. So these patients are left this way, and they're going to develop Eisenmenger syndrome. And the only way to fix them is heart transplant. There's no way you can repair this. So this tetralogy. So this is the outflow tract lesion. That's the VSD. The aorta sitting on top of both ventricles. Look at how hypertrophied the right ventricle is. So the surgeon will patch this hole, resect all the excess tissue here, and then repair the mitral valve. So they end up PI, and then over time, they're going to get problems at the outflow tract. And sometimes they have stenosis of the main artery or the branch PAs. Some of these patients need stenting of the pulmonary arteries from time to time, or sometimes a reconstruction of the pulmonary artery. Okay, now the transposition. There are 2 types. We have what I call D transposition or dextro transposition, and then levo L transposition. These are born blue, L transposition are born pink. They look normal like all of us, but they are not normal inside. In D transposition, what you have is, this is the normal arrangement. IVC, SVC, right atrium, right ventricle, tricuspid valve, pulmonary valve, aorta, and then mitral valve, left ventricle. This is a pulmonary, I say aorta, no, pulmonary. Aorta here. So there's a normal arrangement. In D transposition, what you have is, normally instead of the great vessel crisscrossing like this, they lie next to each other. So when this is doing the looping, it's incomplete. So the aorta comes off the right ventricle, the pulmonary comes off the left ventricle. So instead of the circulation crisscrossing, it's just doing this. So venous blood from the lower half of the body will come from the IVC, then the SVC from the upper part, go across a tricuspid valve into a right ventricle, across aortic valve into the pulmonary, to the aorta, and then back to the body. So blue blood comes from the body, returns back to the body. Whereas the pink blood comes from the lungs, the pulmonary veins, across a mitral valve, left ventricle, then through a pulmonary valve back to the lungs. So the 2 circulations are sort of independent. So in this case, when they are born, they are blue. And the first procedure that the pediatric cardiologist will do, we call it hand-long atrial septostomy. They take the patient to the cath lab and pass a guide wire from the IVC and then probe the fossa ovale and then pass a balloon across it, a big balloon, and then inflate it in the left side and then pull the balloon and blow the septum wide open so that there can be mixing of blood. So when they are born this way, you keep the duct open here, the PDA, so there'll be some mixing of blood here. And then you're creating a large atrial septal defect for the blood to mix in the atria and get some oxygen blood to the body. And that has to be done day 1 or day 2, as this case will not survive. Then years ago, there were two types of procedure that were done. And you're going to meet this in the labs. They're called mustard and Sennen procedures. The mustard and Sennen procedure, the idea behind them are the same, except that they were described by two surgeons. Aki Sennen was a Swedish surgeon. He came up with this idea where he used the atrial wall. So he used the atrial wall to create what we call a baffle. It's like he create a tube and direct the arterial blood in the left atrium and shunt it across the tricuspid valve here so that it will go here. So you have what we call atrial baffles coming from the pulmonary veins with the atrial wall and then move it across the septum. First of all, at surgery, they remove the atrial septum completely and then create these pathways over here, then goes into the body. Then the venous blood from here, they also will move it across the mitral valve so that it go to the lungs. So the left ventricle will now be pushing to the, it will continue pushing to the lungs, but it will be carrying deoxygenated blood. The right ventricle will push to the body, then it will carry oxygenated blood. So that was Sennen's idea. Then Bill Mustard, who was a surgeon in Toronto at a hospital for sick children, came up with the same idea that Sennen came up with, but he used the pericardial tissue to create these baffles. So he takes the pericardium and then, create these baffles and then use them to, it's like a tube, shunt the blood this way. And so they crisscross inside the atrium and go to the ventricles. Now, these patients who grow up, but they also have problems down the line. They can get kinking of these baffles, they can get stenosis of these baffles, or they can get erosion of these baffles. Because there's a lot of scar tissue from this cell, they get a lot of arrhythmias in the atrium. They get sick sinus syndrome. Most of these patients will need a pacemaker. Patients who got a mustard and Sennen, at some point, we need a heart transplant because the morphologic right ventricle, which is pumping to the body, is not strong enough to do the work of the left ventricle. So eventually it fails. So they need transplant. Now, because Mustard came up with this idea in Toronto, and those who train in North America went to Toronto to study under Mustard. So the North Americans did Mustard procedure. The Europeans studied under Sennen in Sweden, so they did a Sennen procedure. But occasionally you see a patient here who has had Sennen. So that's the basic idea behind the two. And they are fixed, but not completely. They're going to need procedure done as they go through life. Now, L transposition, I thought I had a slide here. In L transposition, what happens is, I have a slide. Oh, no, it's not here. In L transposition, what happens is, in addition to the great vessels lying parallel to each other, these ventricles, doing the looping, something goes wrong. So the left ventricle ends up on the right side and the right ventricle ends up on the left side. And then when the great valves invert, they go with their, when the ventricles invert, they go with their great valves. So the tricuspid valve will always go with the right ventricle. The mitral valve will also go with the left ventricle. So in this patient, what you have is you have deoxygenated blood coming into the right atrium, going across a mitral valve to a left ventricle. Then the left ventricle is pumping the blood to the pulmonary, to the lungs. And on the left side, you have oxygenated blood coming to the left atrium, pump across a tricuspid valve, to a right ventricle, pumping the blood to the body. So these look normal like you and I. They are pink, but their ventricles are in the wrong position. And the same way, the morphologic right ventricle, which is pumping blood on the systemic side, will fail. And this patient at some point will need a transplant. They also get problem with the tricuspid valve here, which is the systemic AV valve. You get a lot of regurgitation of this valve. And one of these patients are very, very difficult to image in the echo lab. And in fact, if somebody comes in and you put a probe at the parasternal area and you can see things well, the way they are supposed to look like, think of L transposition oftentimes. Then go to the apex. And then in the apical view, if you're able to see them, you see that this chamber is trabeculated. You may see the moderator band that will tell you it is the right ventricle. And then the AV valve here will be displaced towards the apex. It will be a bit closer to the apex than the AV valve here. That will tell you that's a morphologic mitral valve with a right ventricle in the systemic position, that is L transposition. And because of the looping, they get AV block 1 to 2% a year. So sometimes they will present as AV block, complete heart block. So that's one of the most common initial presentations. And then they'll get AV block. Then eventually this morphologic right ventricle will fail. And then they need a transplant. And they can go through life and they look normal like everybody else until they present with AV block. I have one patient in Salt City who was a physician. He was 65 years old. He went through medical school. Then he was practicing medicine, and one day he was hiking at the Salt Lake Mountains and he passed out. Brought him to the emergency room. He did an echo, he had L transposition, he got a pacemaker. Now 65 is listed, he's waiting for transplant. So they can go through life unbeknownst to them with a right ventricle pumping blood to the rest of the body, which eventually will fail. Now, one thing I forgot to mention, the way to fix the detransposition, I said we use a mustard and then the sending procedures. In 1973, there was a Brazilian surgeon, Jetin, came up with a brilliant idea. Because later on, initially, our forebears, when they started doing this surgery, they didn't realize these patients were going to have all these complications later on in life, like the sending and the mustard. So later on, when they started having complications, people started thinking again, how else to fix these patients? So Jetin came up with this idea, now called arterial switch. Now the sending and the mustard, those procedures are also, if you come across the word atrial switch, that is, you are switching the atrium. It means the patient has sending or mustard, because you are taking blood from the left atrium and directing it to the right side, assuming that the left atrium is here and the right atrium is on there. So that's called atrial switch. That is mustard procedure or sending procedure. This other procedure is called arterial switch. You are switching the great arteries. So what Jetin came up with, his idea was you cut these great arteries across, above the AV valves. So you transect the pulmonary artery here, transect the aorta here, and then switch them. So you move the aorta here to here. So what you have is, you still have oxygenated blood here, left atrium, mitral valve, left ventricle. Now, the blood is being pushed across a pulmonary valve here, but then the rest is the aorta. So when you do that, then you also have to cut the coronary arteries here. You remove what you call coronary buttons. You have to remove the coronary arteries here and come and transplant the coronary arteries on this side, because the coronary arteries are attached here. So you cut around the coronary arteries and move them, and you reattach them right over here. So they get stenosis at the point of insertion of the coronary arteries. That's one of the problems they get. And they also get aneurysm at the point where you're connecting the aorta to the pulmonary artery here. And they get regurgitation of this pulmonic valve. And now on this side, so this is the pulmonary artery, it comes here, and then this is the aortic valve, and then on top is the pulmonary artery going here. So arterial switch. And this surgery, the thing described in 1973. So the patients who are born now are all going through arterial switch instead of atrial switch. So you see the master and seniors in their 40s, 50s above. The arterial switch are now coming from the pediatric age who have had the switching of the arteries, but they also get problems. Almost all these AV valves, and now we call these valves, this pulmonary valve will be, if you come across it in the literature, it's called neo-aortic valve, and they call it neo-pulmonic valve. They call it neo-aorta, neo-pulmonary artery. They get aneurysm at the point where you are connecting these arteries. They get regurgitation of all these AV valves, and then they can get coronary osteostenosis. So these patients, like maybe look at the guidelines, maybe every couple of years, maybe once every 3 or 5 years, have to do stress tests to make sure they are not getting coronary stenosis and therefore ischemia. I had one patient, so who was just 18 years old, and already the RCA had been bypassed because he got stenosis at the point of the insertion of the right coronary artery. So already the right coronary has been bypassed, and the guy is only 18. So they are fixed, so to speak, but they are waiting to have another surgery as they grown up. So that's the type of surgery that's being done now, called arterial switch. Now, the next group, maybe the tricuspid atresia. And these patients are born blue. One of the initial procedures, a gland, where we tie the pulmonary artery to subclavian to get blood to the lungs. And then at a later time, the surgeons will go in and put a graft from here to the pulmonary artery, and then use the graft to go from here to the pulmonary artery, and then this will pump to the body. These patients will also, they need transplant, like Lisa that I was talking about. This is a patient who developed clubbing from Eisenmenger syndrome. Yeah, they were born blue. And I think I have another slide. I think I will stop here and then open the floor for any questions.
So you're gonna move up to our lab? You're gonna move up to our lab?
Yes.
Okay. We'll make you an office.
Yeah.
I have one question on the Eisenmengers. Do they have moderator band on the tricuspid, on the right side? Because the tricuspid valve is so.
The tricuspid valve, if you look at especially in the apical view, look at the AV valve, the tricuspid valve is always a bit down compared to the insertion of the mitral valve. So it's closer to the apex.
Right.
That's one way to distinguish which one is the tricuspid valve. And then the moderator band will be in the RV because
So it's still there?
Yeah, the mitral valve, the tricuspid, they always go with their ventricles. They don't go without the ventricles. So if they are going to invert, the tricuspid valve will go with the RV.
I just thought it might be absent. That was my question.
No.
The moderator band would be absent.
No, it was.
I'm sorry, I said the wrong word. Epstein.
Epstein.
There's still a moderator band with Epstein.
And you may not have the moderator band because they have abnormality, because basically there's very little right ventricle. Yeah. Yeah. In most patients, sometimes there's very little right ventricle, so you may not see the moderator band.
Dealing with L-trans question. We use the term systemic ventricle.
Yes.
What's the correct verbiage for the pulmonary
Ventricle. Okay, so yes, we use systemic ventricle. When you say systemic ventricle, you mean what is pumping the systemic circulation. So I will use the term systemic ventricle and then sometimes parentheses morphologic right ventricle to identify this is a systemic ventricle. Because you use that systemic ventricle, somebody may think that you are thinking the morphologic left ventricle. So I use systemic ventricle, then parentheses morphologic right ventricle.
So what would you say about the morphologic left ventricle? What would you call
We call it subpulmonary ventricle.
subpulmonary
Uh-huh.
ventricle? Okay.
Yeah, that's below the pulmonary valve. Subpulmonary ventricle. So that's what we call it. Morphologic left ventricle is a subpulmonary ventricle. That's a ventricle pumping to the lungs. And then I use systemic AV valve versus pulmonic AV valve. I said systemic AV valve is a percussive valve, and then pulmonic AV valve is a mitral valve. Recently we had a case at a hospital here with a patient with a L transposition. Who had L transposition also had a tetralogy. So yes, they had a combo, and yeah, and then yes, and these patients are very, very difficult to image. Yeah.
I tried to transfer. It wasn't very successful.
It's very, 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 very rare. In fact, this is the only case I've had having both transposition and then tetralogy. Most of the time they are separate. Yeah.
Are you seeing now an increased incident of like new congenital heart disease with all the things they're doing intrauterine, or because of early detection, people are making choices to?
Okay, so because the technology has improved so much that these days the pediatric cardiologists can make diagnosis even in utero. They can make diagnosis. So we send this, especially even a pregnant congenital disease. We make all of them get echoes after 30 weeks of pregnancy. And if they have the kids have a major defect, we can pick it up in utero. And then sometimes we plan the surgery, the delivery accordingly. That the girl is going to deliver at, say, a community hospital. So no, come to the tertiary hospital where the kid will get attention right at the time of the kid is going to come out blue, needs to be taken care of right away. So yes, we can make prenatal diagnosis of most of these genetic abnormalities. And we think almost every one of them has a genetic basis. So as these genes are being discovered and then described, we'll be able to do more. And then if a lady carries any congenital heart disease, there's a 1 to 5% chance that the kid will carry some form of congenital heart disease. If the man is the one who had a congenital heart disease, there's 1 to 2% chance that the kid will carry some form of congenital heart disease. I had one patient, Salt Lake City, who had a bicuspid valve, and his first child also had bicuspid valve. And in the case, it was so severe that the kid was blue. There was blue at birth. So day one, we had to do balloon valvuloplasty and open the valve for the kid to survive. He's now 20 years old. But his dad's disease is mild, but the kid is going to need surgery in the next 5 years to replace the aortic valve.
1 to 2%.
Yeah, 1-2% for the male and 1 to 5% for the lady. And then so if the lady is pregnant, they need to be screened after 30 weeks to make sure the kid doesn't have something major. Like say if they have hypoplastic left heart syndrome, they have to be delivered at a tertiary hospital where there's immediate care. If it's a community hospital, they won't survive. Yeah.
Thank you.
Yeah.
Thank you.
Welcome.
Well, I have to focus so I can ask questions.
So to the text in the lab, if you come across any of these and you are not sure, just call me, and then I can come and help you through the study and make things clear.
For the Epstein's, you said that there's usually a chance that they have a PFO, right?
Yeah, they have a PFO or an ASD.
So let's say that we had a patient like that. Would you want us to
Oftentimes you see it with a color Doppler that is not needed.
Okay.
Yeah. I mean, it's so obvious that you don't need it. And sometimes some of the patients, they present, one of the common way they present is they can exercise and have syncope. But when they exercise, they increase pressure on the right side and shunt the other way. And then that's when they become hypoxic during exercise. They're on the treadmill and they are desaturation because they are shunting from right to left. It's a very common presentation in this patient, FCs. Okay. Thank you for coming.
Thank you.